Perceive, process, perform. Do you need inspiration for your practice, or do you simply need to practice inspiration? With this series, we aim to do both. Give us 15 minutes and we'll give you practice inspiration.
My name is Dentist Abbott. I practice in Dallas, Texas, and this is my practice inspiration. So it was spring of 2006 when I got a phone call from a woman, and she was kind of frantic, and this lady was actually a patient of mine that had moved away, and I knew that she had moved. She had told us, we're going to be moving. I'm not going to be here anymore, and so we, had said our goodbyes and stuff. And she called me, and she was kind of panicking. She said, "Dr. Abbott," she goes, "can you help me?" And I was like, "Sure. What's going on?" And she said, "My husband went to the dentist, and they wouldn't take him as a patient." And I was like, "Well, why not?" She said, "Well, he's in remission from cancer, and the doctor just didn't feel like he knew what to do and said that he would need to go someplace else. So I don't know who to call. Can we possibly please come back and see you?" And I said, "Absolutely." But the thing was that they lived about 2 hours away now. But she actually made arrangements, she and her husband, and they came back over the course of about 6 months as we rehabilitated him. And when I saw him the first time, this is what Ron looked like. So he had experienced some dry mouth from the chemotherapy that he'd had, and he was actually a really fortunate man because he was actually in remission from lung cancer. And so, here he had beaten this disease that not a lot of people beat, and he had this new outtake on life, and everything was good, but he was having pain in the right side, and just didn't know where to turn because he had been turned down by this dentist, and they were afraid that was going to happen time and time again. So I saw him, we took care of him, and over time I started thinking to myself, I thought, if this guy's had problems finding somebody to work on him, then there are probably other people out there who are having problems. And if he's having these kinds of issues with dry mouth and the decay that follows, then there've got to be other people that are having these things. So I started diving deeper. I started doing some investigating and some research and learning on my own and trying to figure out really what happens when a patient goes through cancer treatment. And what I found is this, we all knew from dental school that, hey, head and neck patients that are going to go through radiation, they're going to be at risk for osteonecrosis of the jaw, and you can't do this, you can't do that, you need to be careful, but we really didn't learn much more than that. But what I found is there's this whole new world out there that needs our help, and these oncology patients and cancer survivors have, some of them, a lifetime of needs that don't go away. So I wanted to share with you a little bit about what I found and what that means and how it's shaped my practice and how it's made me a different clinician and really moved my practice in another direction. So, in chemotherapy, it's not just the dry mouth. It's also immunosuppression. It is the inability to fight infection. It's the inability to fight disease. And this right here, this is a petri dish of stuff and gunk and microbes. And so we need to make sure that our patients and the people that we're going to be able to take care of are well protected as they go through chemotherapy, as their white counts drop, as their platelets drop, as they become at risk for bleeding, as they become at risk for immunosuppression and can't fight those infections and have xerostomia and possibly have mouth sores. We need to be there to step in to know how to manage those patients and keep them safe. In patients that are going through head and neck cancer, a lot of them do end up with head and neck radiation, and those patients actually have a lifetime of needs. They have, not just while they're going through treatment, but throughout their life, side effects that linger from head and neck radiation, even with the type that we give now as IMRT or intensity modulated radiation therapy, where it's very precise. Still, these patients have ongoing oral side effects and needs that happen to require our expertise. This is an area of drugs that I think many people are not familiar with, and that is this, IV bisphosphonate therapy. More and more people are being given IV bisphosphonate therapy to take care of bone metastases. So if the cancer is spread from the primary site into the bones, we have a different type of scenario here. And we have different kinds of needs, and we have different kinds of limitations. A lot of the times, and most of the time, actually all the time with IV bisphosphonates, in my opinion, we are only going to affect the bone or do trauma to the bone, and that would mean doing an extraction, doing an implant, doing periosurgery, doing orthodontia, those kinds of things, if it is an absolute emergency and we have no other choice, because we do run the risk of having medication-related osteonecrosis of the jaw. It's very difficult to treat when that happens. It's extremely painful when that happens for the patient. The patient a lot of times will lose their fight because they just lose the will. If you've ever smelt perio breath and multiply that by 1,000,000, you've started to kind of understand what it smells like when you have osteonecrosis. And so I've had patients that have actually sequestered themselves away from their family because they felt like they were so offensive to family members, and they did not want to do that to their family member, not to mention the pain and suffering that they were going through on their own. So we need to know what these drugs are. We need to know about Zometa. We need to know about Iridia. We need to ask the questions in our health histories. Are these drugs being given? Will they be, entering into the way that I need to treatment plan my treatment for this patient? Finally, there is this class of people who will have to have facial reconstruction due to some kind of cancer, either of the upper jaw, the lower jaw, most of the time mandible, but it can be the upper as well. It can become disfiguring. These patients have a lot of issues because when they look in the mirror in the morning, the person that they know, the husband of their wife or the father of their children, isn't looking back at them anymore. So that's a really hard and difficult thing to come to grasp with, not only emotionally and psychologically, but also physically. And whenever you're going out in public and seeing other people and they stop or they look or they turn and they wonder, or little kids will point, they're dealing with so much. We need to be able to help them come in and at least give them some good quality of life to reconstruct in a way that gives them function, that gives them as much encouragement and confidence as we possibly can, and restores to them some semblance of a quality of life. Because survivorship is not just about living after cancer, it's living after cancer. It's surviving, it's having life and good quality of life, and being with your family, being with your loved ones, still making an impact in what you do to those around you. That's what life after cancer is about. So what we do in our practice is we combine really 3 elements and wrap those all together. So obviously I'm trained as a dentist, so we do dentistry. We do general dentistry and take care of all of the dental needs of the patient, either before, during, or after cancer treatment. But I also have extensive training in oral medicine, and that gives me an ability to kind of come along and say, hey, now I know what I need to do with this infection, or I know what I need to do in this situation, or I know how to manage this oral mucositis, these mouth sores that have come up because of chemo or because of head and neck radiation. And I know what we need to do here, and I can help you with this. But I've had to learn a lot about what goes on in the midst of cancer and learn how cancer care and what happens during treatment and what happens during survivorship affects these other elements, affects the dental, affects the oral health part, and how those all then incorporate together and integrate together to really become this cohesive area, this functioning area of dental medicine called dental oncology. And so that's really what we do, is it's not limited to oral cancer. And so many people are like, oh, well, you manage oral cancer all the time. I'm like, yeah, I do take care of oral cancer. And I have a lot of patients who are head and neck patients, but I also see breast and lung and liver and kidney cancer patients, or even thyroid or lymphoma or leukemia or multiple myeloma, and the list goes on. So we really can impact, and I found what this has been this great bridge between that world of medicine and that world of dentistry. And what happens when medicine and dentistry collide, I believe, at least in a certain area of it that is about oncology care, is a beautiful mix of what can happen with us practicing with our physician colleagues. So we are very concerned about oral health. We are very concerned about teeth, but we're also concerned about the systemic health of the patient, and the general wellness of the patient and the well-being of the patient and their overall health, and how those two marry together and come together and work in unison together. But that leads to a better quality of life, because that is what I want for my patients, just like I would want for my own family. And that is to have that high, as good of a quality of life in those survivorship years as possible. We do that all in our world of cancer. That's where I live. But I have colleagues who do this in cardiac, and I have colleagues who do this actually in rheumatoid arthritis and other autoimmune diseases. So it's something that is not just limited to cancer care, but that's where I practice, and that's kind of the world I live in. When I sat down and I made this decision to change and go this route, I sat down with my team and I said, listen, we need to understand that we are now part of a bigger team, that we're part of a larger group that extends beyond these four walls, and we really have to start acting like that. And so in order for you to be successful in managing any kind of oncology patient, whether you do it as just a part of your additional practice, or I realize that not everybody's going to go off and do it like I did to where that's really their focus. But even in the patients that you're seeing that have cancer, you need to consider yourself as part of a bigger team. You need to see yourself beyond the four walls of your office. And here are some of the members that come into play whenever we talk about oncology. Oncology nurses and nurse navigators that help the patient navigate through. Oncological surgical teams, the chemo team, those who give infusions of chemotherapy, and the medical oncologists, radiation oncologists, and radiation therapists. Us, of course, in the role that we play in taking care of the patient. Counselors, mental health, psychology, psychiatry. All of those people come into play too to help this part of it and the will to fight and survive. Therapists, lymphedema therapists, swallow therapists, music therapists, physical therapists, occupational therapists, and even clergy, for the mind, the body, and the spirit coming together to take care of this individual as an individual. It's about the patient, and we have to work together. We have to communicate. Let me show you kind of how it works in our world. We get information of history of present illness from a physician. We'll get the oncology treatment plan so we can know what's going to be going on. And then we ask for current blood work, because we have to know, are we keeping this patient safe? Are we starting off baseline and we're good? Or are we into treatment and we have immunosuppression and thrombocytopenia? So ideally, we like to see the patient as soon after a diagnosis of cancer as possible, because then they'll send those patients to us after the diagnosis, and we'll get a chance to take a look at them ahead of any other treatment, so we can catch things early, so we can be preventive and try to spare them from a lot of trouble. There's a lot that I can do to minimize the risk of osteonecrosis. There's a lot that I can do to minimize the risk of oral mucositis lesions if I'm there early on. Then comes the time to communicate, and this happens throughout the process, because we want to make sure that we're providing that care and communicating back to the other team members, and we communicate amongst each other so we all know what's going on. We want to make sure that we're educating the patient between us and the medical colleagues that we have regarding what needs to happen during cancer treatment, but for us specifically, it's about what happens with their oral care before, during, and after their cancer treatment. Then we're at a point where we want to make sure that we've got all the perio in check, that we've got them cleaned up, and we're getting them into treatment as clean as we possibly can. We're going to do what's necessary to get the clearance done to make sure that we've got severe decay addressed, that we've had extractions that need to be done, and that they're all cleaned up, and then we give that dental clearance. We provide the clearance, and the patient's able to move forward. After that clearance then comes additional treatment if they needed to have any done during treatment, if we can. Sometimes that's only emergent, sometimes we'll delay that, but if they're in long regimens, that may happen during the treatment. And we'll continue communicating ongoingly with the oncologist and the rest of the team. We'll work out any dental treatment that's necessary during that time, and then also we hopefully will get them to a point where they're in remission. And then we take care of those people in their survivorship years. We can get information about what their history has been as far as oncology care and make sure that we're doing exactly what needs to be done for them given their specific unique medical history. We can also provide those consulting services for head and neck reconstruction and help rebuild and be a part of that element of reconstruction for those head and neck patients that suffer from disfiguring surgeries. Then, when we do a good job, we get more referrals. And in fact, this is the way I get the majority of my new patients in the practice, is from medical referrals. And when I have a patient who's referred by a physician that comes to me because their physician sent me, and I'm saying we need to get this, this, and this done for clearance, they get it done. So it really has changed the way that we practice and the way that we manage our practice as far as referrals and marketing, because it's really all now done through medicine and the medical community. So I want to leave you with this thought, because sometimes when we talk about worlds colliding, it can be scary. There's a lot of trepidation, there's a lot of fear that comes with, I don't want to get outside my box, I don't want to get outside my comfort zone. I'm cool with my team and what we're doing here, but I would encourage you to make sure that you do step beyond that four-walled boundary whenever you have a patient that has cancer, because I can tell you this, that sometimes when two worlds collide, a better one is formed. I appreciate your attention today, and I hope that this has been at least some way enlightening and inspiring for you. And I realize that you may not be seeing only oncology patients, but when they come through, I hope that this will give you a little bit of insight as to how you can better care for them. Thank you for your attention. Bye-bye.